Hello and welcome to today's webinar, Exploring New Jersey's Efforts to Increase Access to Medications for Addiction Treatment and Primary Care, made possible by the Robert Wood Johnson Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be 3 moderated question and answer sessions during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A brief online evaluation will be emailed to all attendees following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. I will now turn the webinar over to Meryl Schulman, Senior Program Officer at the Center for Healthcare Strategies.
Thanks so much, Travis, and good morning, everyone. Once again, my name is Meryl Schulman, and I'm a Senior Program Officer at the Center for Healthcare Strategies. Welcome to today's webinar on exploring New Jersey's efforts to increase access to medications for addiction treatment. We're really looking forward to today's event, and we have a host of wonderful speakers and champions for addiction medicine on the line, and we are very grateful for the support from the Robert Wood Johnson Foundation that is making this webinar possible today. So we have a packed agenda. Travis, I'm going to ask that you go to the next slide and I will dive right in. On this slide, you can just see a little bit about the Center for Healthcare Strategies, or CHCS as we like to call ourselves. We are a nonprofit organization, excuse me, and we're focused on strengthening the U.S. healthcare system to ensure that people served by Medicaid have better health and more equitable healthcare outcomes. We work with an array of partners. We work with state agencies, managed care organizations, provider groups, consumers, community-based organizations, to do a number of things. First and foremost, to advance effective models for prevention and care delivery, to advance efficient solutions for policies and programs, and lastly, to ensure more equitable outcomes for people facing the greatest needs and health disparities. And we have been privileged, I should say, through support from the Robert Wood Johnson Foundation to help support some of the efforts underway in New Jersey related to office-based addiction treatment, and to help spread the word about the various supports and services that can help providers in offering MAT to people with substance use disorders. And you'll all be hearing a little bit more about that shortly. Next slide, please. So on this slide, you can see today's objectives. We have 3. First and foremost, we hope you walk away with an overview of the New Jersey Matrix model that's really focused on increasing access to office-based addiction treatment, or OBAT, as many of us refer to it as, including any relevant updates for New Jersey providers. Our second objective is to outline supports available to healthcare providers looking to increase their capacity and their comfort level in offering MAT, particularly in the primary care setting. And then lastly, our third objective is to share insights from New Jersey provider champions on the benefits and lessons related to managing addiction treatment and primary care. And we have a number of awesome champions on the line that I'm looking forward to you all hearing from directly. Next slide, please. So here's an outline of our agenda for today. And as Travis mentioned, we will have a number of opportunities for question and answer throughout today's session. So here we are, welcome and introductions. I will then turn it over to our colleagues at New Jersey Medicaid to provide an overview of the Matrix model, and then we'll have time for some question and answer directly related to that. We'll then turn it over to our colleagues at the New Jersey Centers of Excellence and the Camden Coalition of Healthcare Providers, who will be providing an overview of the various resources and support services that are available to providers in the state who are already offering medications for addiction treatment or who are interested in getting started with MAT. And then lastly, we will hear directly from a provider champion who will be talking about his experience integrating substance use disorder treatment into the primary care setting. And as mentioned, we'll have time for Q&A after each of these presentations. Next slide, please. So I think we can go one more, Travis. So with that, I am pleased to turn it over to our colleagues at the state. I will hand it directly over to Steve Tunney, who is Chief Behavioral Health of the Division of Medical Assistance and Health Services. And Steve will be joined by his colleague, Gwen Carrick, who is a behavioral health specialist, also at the Division of Medical Assistance and Health Services at the Department of Human Services. So Steve, I will turn it over to you.
Thank you, Meryl. Good morning, everyone. Thank you for attending our presentation on office-based addiction treatment. Okay, next slide, please. So New Jersey Matrix is composed of 3 different provider groups. Office-based addiction treatment, where we're trying to attract physicians practicing under their professional license. And what makes you an addiction treatment center is having a navigator enrolled. The independent clinics are our largest providers right now. They offer MAT and behavioral health counseling, intensive programming, and they utilize peers rather than use navigators. And the third provider group is our regional centers of excellence, who provide MAT services, education, provide clinical resources, and they most importantly champion medication-assisted treatment for substance use disorder, trying to get the word out and spread MAT across New Jersey. Next slide. So why did we decide to go with office-based addiction treatment? First and foremost is national estimates vary, but approximately 1 in 12 individuals suffer from substance or alcohol abuse disorder. We made the decision early on not to do OBAT, which would have been office-based opioid treatment. We wanted to include all addiction and especially alcohol. According to SAMHSA in 2016 report, only 11% of those people who have been diagnosed with a substance use disorder seek treatment. To give you an idea, in New Jersey, in 2018, we had 2,583 individuals who died from an opioid overdose. And in 2019, we had 80,000 Medicaid members who had a primary diagnosis of substance use or alcohol use disorder on one of their claims. So we're dealing with a large population of people that need help in New Jersey. So that's one of the reasons why we decided to expand our OBAT program. Next slide. So OBAT, we wanted to utilize existing providers. We had a large group of clinics, as I said, and outpatient hospital programs that are doing an excellent job. The clinic centers were mostly focused on methadone treatment. We wanted to expand and go with the buprenorphine, and we wanted to include a large group of untapped providers, our physicians and APNs in private practice. So OBAT supports our integrated care, which is big in New Jersey Medicaid. We've been trying to expand this for a while now. It helps providers to treat not only the addiction, but those comorbidities associated with addiction, like hypertension, CHF, COPD, and most importantly, hepatitis C and HIV is a big project that I know our Division of Mental Health and Addiction Services is seeking to get treatment with. So office-based addiction involves trust and familiarity. We found that a lot of people were not comfortable going to a clinic setting. They had confidence and trust with their providers. They're more willing to talk about their addiction. So another reason we wanted to bring in private practices. And as related, OBAT reduces that stigma associated with community SUD programs. People didn't want others to see them going to a substance abuse program, whereas people go to see their doctor. No one knows what you're going to see your doctor or APN for. Next slide. So SAMHSA defines MAT as a combination of medication treatment and counseling behavioral therapies for a whole patient approach. In New Jersey, because of licensing restrictions, it's not so easy for a provider to provide the behavioral therapy. So we needed to find a way that we could get those individuals referred from the physician offices to our behavioral health providers out into the community. We hope to achieve that through adding the navigator into the practice, and that's the basis for OBAT. So regardless of the setting, multiple research studies have shown that MAT is much more effective when counseling and other behavioral therapies are included. So that's, again, one of the large parts of doing the OBAT program. OBAT's also designed to enhance access and improve utilization of non-methadone MAT services. If you want methadone, like I said, there's no shortage of methadone providers in New Jersey. If you want to go with the buprenorphine, then you can do that either through one of the clinics or through the OBAT programs. Navigators connect patients with community-based counseling and behavioral therapies. Again, that's an important component. This was an area that was a big concern. We didn't want individuals just getting the medication-assisted treatment. We want to get them connected to the counseling and behavioral health therapies, which help to encourage them to stay engaged in treatment. It also expands opportunities for vocational programs and housing supports, legal supports, other stressors. It helps people to address those things that add stress to their lives that contribute to their substance use disorder. And again, helps them to remain in treatment. Next slide. So to be an OBAT provider, you need to be an office-based provider working under the authority of your own professional license. Unlike a clinic that is licensed by the Department of Health, that you're just strictly offered the license issued to you by the Board of Nursing or the medical board. You need to be DATA 2000 waivered in order to prescribe buprenorphine. You have to employ an individual who meets the requirements for being a navigator. In fee-for-service, that would require you to complete an addendum. It's a simple one-page form where we connect that navigator to your practice, your group practice. In the MCO world, managed care organization world, it's just an attestation that's provided that you have an individual who's functioning as a navigator, and then they designate you as an OBAT provider. We expect OBAT providers to promote integrated care. Again, that's another big thing that's part of the goals of New Jersey Medicaid is to expand integrated care, and this is a good opportunity. And we expect providers also to meet best practice guidelines. The asterisk is, I'm pretty sure they still have this, but the Division of Medical Assistance and Health Services works with the Division of Mental Health, and they were providing free trainings for individuals. So we have an opportunity for individuals who are not yet waivered to become waivered, and then they'll be able to participate as an OBAT provider. Next slide. Okay, so as I said, the navigator service is probably, it's the most unique part of the office-based addiction treatment. The physicians are comfortable doing the medical portion. It's the psychosocial portion that is a little more outside of their world. So navigators, we tried to get people that worked in offices so they can utilize registered nurses, licensed practical nurses, social workers, any individual with a bachelor's degree, as long as they had 2 years of life experience. Life experience means you either had the addiction yourself or someone in your family, or it could even be work related. So we kept that as broad as possible. We later added an associate's degree or a certified medical assistant, as long as the same thing, you had that 4 years of life experience. We expect the navigators to meet with the patient independently. They are more than welcome to meet with the primary care provider, but it's not necessary. The primary care doctor can take care of the MAT. The navigator can meet separately and address those psychosocial issues whenever it's a convenient time with the patients. They function primarily to address the psychosocial needs, as I stated, but they can do other duties. And by no means are they restricted to only doing navigator services. So we realized that OBAT isn't going to be, for most providers, the entire service that they provide. So you can utilize an individual, again, that's like a certified medical assistant, and then they could do these duties on the side, or navigators can actually work for more than one provider. So they could be part-time and come in 1 day a week for one group and then do another group, and so on. So that's a good opportunity for someone that really wants to specialize in just doing navigator services so that they can work for more than one provider. Next slide. So Navigators work with the patient to establish a comprehensive individualized treatment plan. That's a little scary to some of the people that aren't familiar with that term, but we just really wanted to have an organized scheme that the navigators were following, even if they're addressing non-medical factors that had those impacts on treatment. So we want them to connect patients with social service organizations, recovery supports, hopefully provide family education and involve the family in treatment. This is something that the independent clinics do as well. It's important to involve those family members because this is a disease that affects everyone that it comes in contact with. Make referrals to alternate levels of care as required. So sometimes an individual needs to have detox. Sometimes they need to go on to a residential setting. They need to get away from an environment that's contributing to their addiction. So you're more than willing to do that. They can make calls to our IME, utilizing their 800 number, or if they have connections with providers in the community, they can make referrals directly. Complex cases and situations do arise, and they can coordinate referrals for the practice with either consultative services at other clinics, or they can make they can make referrals to our centers of excellence that could offer additional clinical experience. Next slide. So when we first started office-based addiction treatment, we had a team of stakeholders that we brought in, and just to find out why providers were not treating patients that had addiction services as much as what we would have liked to have seen. So the initial barriers that were raised during those committee meetings were prior authorization requirements, primarily prescriptions. This one surprised me that this came out first, because usually in Medicaid, the first problem that comes up is rates. So this was a good sign that it was actually the prior authorization requirements. Discerning what services are covered by managed care and or state fee-for-service. This is unfortunately a part of the Medicaid world, and it can be confusing. So that was good that we noted that. Low reimbursement rates was brought up. A lack of experience dealing with substance use disorder. I think we heard from one of the physicians that was on the group that of their thousands of hours of training in medical school, they got about 15 minutes in SUD training. So that was another thing that we paid a lot of attention to. And probably most importantly, in terms of the navigators, where do we send patients after you prescribe MAT? It was that next step that a lot of the providers were not comfortable. So next slide. So the first thing we did was set out to address these barriers. So for rates, we had the evaluation and management rates for any certified OBAT provider raised to 100% of the Medicare rate, office rate. Recognizing that an intake evaluation can be timely and takes a lot of effort for everyone that's involved, we raised the rate for the intake evaluation to $438.17. Navigator has to do a separate intake, so they're paid separately an additional $152 for their intake. All OBAT services were decided to be covered by managed care, again, supporting that integration of care and the fact that we were trying to attract primarily primary care physicians and physician groups. But that was our MCO's world, so we wanted to make sure that they were brought into this process as well. And then effective April 1st of 2019, we eliminated all prior authorization for the medications and or bundled services associated with administering those medications for the treatment of opioid and alcohol use. Next slide, please. In September of 2020, OVAT providers were no longer limited to primary care providers. We recognized we were missing a large group of providers that it didn't matter. We had a couple emergency room physicians that wanted to open up an office and then treat our people that had substance use disorder. We had a psychiatrist group that wanted to open up. So we expanded that and took it out of the primary care provider world and expanded to anybody with that professional license in an office. We added that they could bill for the certified medical assistants as providing navigator services. And we provided guidance that allowed licensed practitioners within their scope of practice to become navigators. We had a couple APN groups that wanted to utilize their APNs as navigators. The rule is if you write the MAT, the script for the MAT, then another provider would have to do the actual navigator. We didn't want the same person doing both roles, but we did expand that. So if you were a physician and you wanted the 2 navigator services, we covered it all. If you have a license that allows it, you're good to go. We had an issue where the MCOs were requiring a navigator and physician intake on the same date of service. Recognizing navigators were often part-time positions, we expanded that to 7 days. So you did not have to be seen on the same date. And community pharmacies can now bill for MAT products for individuals recently released from jail. When you are in jail, there's an indicator that gets put in the Medicaid so that we do not pay for services. Like other individuals don't use their Medicaid card while they're in jail. Recognizing that when they come out of jail, it takes several days to get that updated into our system, but they needed MAT product right away. We were able to address that barrier as well. Next slide. Similarly, we understand why substance use disorder patients are in lock-in, but sometimes they ran out of stock. So we had that exclusion just for MAT related medications so that if they're out of stock, they can go and get that medication at any pharmacy without requiring prior authorization, which was timely from the managed care organization. And then we had training on core competencies. That was a big issue. People were unfamiliar with the navigator concept. It was new to a lot of people. Camden Coalition came in and created a program where they trained our navigators, which was excellent. So this is something that I highly recommend. I think that it pays off immensely, where they basically just go through engagement skills, navigation skills, how to appropriately refer someone, and resource identification is a big one, that they were able to share resources that were common across New Jersey to make sure that all individuals knew, or at least had the opportunity to know, where they could refer these people. Next slide, please. Then we have our centers of excellence. These are institutions of medical learning. They have to be Rutgers University Medical School, Newark, and Cooper Medical School, Rowan University, and Rowan University School of Osteopathic Medicine. Rutgers is our northern COE, and Cooper is our southern COE with Rowan. Their main goal was to increase statewide capacity. We were looking to get practices that were not doing MAT to start treating their whole patient. If you can treat a patient for congestive heart failure, you can treat them for substance use disorder. So that was part of their initial marching orders, I guess you would say, to go out and to try and increase that statewide capacity, get more people involved. So there was a lot of mentoring and education. They created OBAT materials to support new practices, created innovative models of service delivery. We had a lot of really good early meetings with our commissioner's office, who was very supportive of this program. And a lot of new ideas and things were approved because of that. They launched a telemonitoring educational series, so providers could do that without having to physically get together and meet. They did provide in-person county-based learning collaboratives where they would actually meet with providers, and then they could all discuss whatever issues were of concern to them or what the latest treatments were. They offered training opportunities to become OBAT providers. Again, that was the training that was paid for through a grant from our Division Mental Health and Addiction Services. Next slide. There was a desire to provide fellowships to increase the pool of substance use disorder specialists that are available in New Jersey. There's a shortage, much as there's a shortage of several specialties. So I think personally, I think that was one of the good ideas that they had, and they are following through with that now. They promoted evidence-based clinical treatment. They provide consultation for medically complex cases. They do have a 24-hour phone line. where they will either answer the line will be answered quickly, or they get back to you within a reasonable amount of time. So if you had a patient and you had concerns or any kind of questions, they were there for them. Provided treatments for individuals with multiple failed treatment attempts or complex comorbidity. So if you were a provider and you had somebody in your office and maybe that was beyond what you were capable of providing, then you could reach out to them, and if possible, then they could assume that treatment for that patient. They're looking to expand urgent access. This is probably our biggest need right now. We're looking at ways to try and get people access to MAT when they need it or when they decide that they're ready. So we have people, if they make that decision at 2 o'clock in the morning and there's no place for them to get MAT other than going through an emergency room, we would like to be able to have something set up where they could get that taken care of and prevent them from going after illegal narcotics. Get them started on a controlled treatment, and developing searchable databases for providers and patients. So that would be a great resource when that is available as well. Next slide. The other component of our matrix model, New Jersey matrix, is we call them premier providers. Providers who provide both the medical counseling and components of OBAT under a clinic license. These clinics do a really good job in New Jersey. They see a lot of patients. So sometimes someone could come into an office-based addiction treatment program and not quite be ready, or ready that they need more support than they can get through just taking the buprenorphine alone. So these clinics are available. They provide IOP, and they provide residential treatment services, detox services. They do provide the MAT services as well. So they are there, they continue to be there, and they want to be an active partner. Our initial goal was there would be a lot of back and forth depending on the patient needs. We haven't quite reached that point yet, but that would be nice if there was that openness where individuals could just move around from providers to get the most appropriate level of care. Federally qualified health centers are allowed to provide MAT, at least buprenorphine and naltrexone, but they cannot bill for that separately. So that's something we're currently working with them to come up with some kind of a payment model that will keep everybody happy and make them a part of the system as well. They're obviously champions in integrated care, so we would like to include them. And OTPs are an independent clinic. The certified community behavioral health centers are somewhat like an FQHC, new provider site for New Jersey, and they came out and they started doing substance use treatment, and they're doing a pretty good job with it. So they're a new partner with us. And then just the last one is the substance use independent clinics, and they generally do the counseling, but some of them have gotten licensed and are now integrated and can provide MAT services as well. I think that's the last slide. Correct. So this go back to you, Meryl.
Yeah, thanks so much, Steve. That was a really informative presentation and a great way to start today's webinar. So just a reminder, I know a couple of questions have come in, but feel free to drop any questions that you have by clicking the Q&A icon located at the bottom of the screen. Travis, I think that we can drop the slides for now. We have a little less than 10 minutes for questions, and Steve and Gwen, I just invite you to join me here on video. And I think I'll start with two questions that actually came through from Lee. Thank you for your questions, Lee. And the first question is, who can receive the rate for intakes? Only the private practitioners. Can an FQHC receive that reimbursement rate for a MAT assessment? So I'm just wondering if Steve or Gwen, you want to answer that question about the rate for intakes.
Steve, you want to take this one? I know you already mentioned about the FQHCs.
This is where I'm going to fess up, and I have a little bit of a hearing problem, so I missed part of the question. So
no worries.
If you heard it, please answer it.
Oh, okay. Go
I
ahead,
can
Meryl.
repeat it, Steve, and also feel free to, I know you did mention a little bit about the FQHCs and the payment, but I think feel free to touch upon that as well. But Lee was asking who can receive the rate for intakes. Is it only private practitioners? And are FQHCs able to receive that reimbursement rate for a MAT assessment?
That's something that we will definitely talk about. I think the rule is, see, FQHCs get paid through an encounter, but if you provide a service where the payment is higher than their encounter rate, then I believe they're entitled to that payment. So that is something that we can discuss. The other services, the payment rates for the FQHC through their encounters are higher, and that's what the issue is. So they would not be able to bill separately for a navigator at this time. Again, we have some meetings scheduled. We're meeting internally with our fiscal folks to see what we can agree to, what we can do. But that is on our agenda. We want to take advantage of the FQHC's ability to provide this service, and we want to make sure that you're fairly compensated.
Thanks, Steve. And then a related question for you and Gwen, can an FQHC bill for a peer recovery support specialist? If so, what codes are used?
So an FQHC can only bill for one of the core providers right now. So you have to be a physician, APN, what are the other ones? A licensed clinical social worker. So like I said, it's a different billing system, and that wasn't really built for OBAT. So we'll have to find ways to make modifications to that. At this point, it doesn't exist. There is no way to pay for that.
Thank you. So we actually had a couple of questions submitted ahead of the webinar, and so I want to make sure we get to those, and then Peter, I'll turn it over to your question. But one of the questions that came through is, do you have to be an OBAT provider to prescribe medications for addiction treatment?
No. Obviously, anybody with a license that allows them to prescribe can write those prescriptions as long as they have the data waiver. The OBAT, having a navigator associated with your group practice allows you to get the enhanced rates.
Thanks for clarifying that. So a different type of question, someone asked, is there a registry of providers offering office-based addiction treatment that hospitals can access?
There is some limited information available in the NJ SAMS directory. New Jersey SAMS is the substance abuse monitoring system for New Jersey. There is a provider directory listed in there. It'll give you general lists of providers for, but they do not differentiate between a prescriber of MAT and a designated OBAT provider. So it is not a perfect system. However, it can at least get you started. We're working in this area to develop something that is a little more formalized.
Thanks, Gwen. So this is an interesting question from Peter. Peter, thank you for your question. And Peter writes, I'm an emergency room physician that is practicing addiction medicine 2 days a week in Orange County, New York. Is there a New Jersey matrix equivalent in neighboring New York? I'm not sure, Steve or Gwen, if you know the answer to that, but I thought I'd open that up to the extent you're familiar with anything happening in New York, or if you've spoken to their Medicaid agency about related efforts.
I don't know, Steve. I haven't looked at this in a while. I know Pennsylvania does, Virginia. We looked at Rhode Island, a couple other states we looked at, but I don't know that we looked at New York. And if we did, maybe we didn't find any, but this was probably 3-4 years ago now. So I don't know if New York has something now.
Yeah,
and I'm not aware either.
And Peter, by the way, if you hear relevant efforts in New York, we'd love to hear about them. So we have time for 1 or 2 more questions. Someone has asked, what is the appropriate submission for reimbursement for the patient navigator code?
Well, there's a particular rate for the Navigator intake assessment, and then there is a weekly, is it weekly, Steve, or is it?
Yeah.
Yeah.
So we pay weekly for 6 weeks, 6 to 8 weeks, and then it's monthly at that point. So it's a bundled rate for the entire week. No matter how many times you see the person, you have to see them at least once. So for the first 8 weeks, you can bill, you get the $76. It happens to be the rate for that person. And then it goes to monthly when they're in the maintenance phase. And if a person does have something that changes in their life where they need to go back, we're working on having the ability to reset those 8 weeks so that you can see them more frequently.
And just a last quick question that's related. Someone has asked, can you clarify who specifically can bill for Navigator services?
Who can bill for it in terms of the practice? They're part of the group practice, so the group practice bills for their services. They're listed as the rendering provider, servicing provider, whichever the correct term is, I forget. But we require that under the Affordable Care Act. We have to identify who actually provided the service, but the billing would be the group practice. And it's whoever is listed or associated as your navigator.
Thank you, Steve, and thank you, Gwen. So we need to pivot to our next presentation, but I just want to encourage folks, we will have additional time for questions at the end for all of the presenters. So to the extent something comes up or you have an additional question for the team at New Jersey Medicaid, feel free to drop that into the Q&A icon located at the bottom of the screen. So Travis, I think we can pull the slides back up now and go to the next slide, please. And we'll start to hear more about the specific resources and support services made available to providers who are interested in offering medications for addiction treatment in New Jersey. So I am pleased to introduce our next speakers. We'll be joined by Caitlin Baston, who is the center head at the Cooper Center for Healing, the division head of the addiction medicine at Cooper University Healthcare, and also is a lead at the Centers for the Southern Center of Excellence. Clement Chen, who's a clinical pharmacist and academic detailer at the Department of Psychiatry Care Center at Rutgers, New Jersey Medical School. Iris Jones, who is a manager of clinical operations and a therapist, also at the Addiction Medicine Center for Healing at Cooper. Moy Pan from the Camden Coalition. She is a program manager of clinical redesign services. We are also joined by Dr. Landon Taylor, who is an assistant professor and a mentor at Rowan, the Southern New Jersey Centers of Excellence, and Dr. Erin Zerbo, who is an associate professor of psychiatry at Rutgers and the director of the Northern New Jersey MAT Center of Excellence. So we have an awesome team here, and Moy, I think I'm going to turn it over to you first to share a little bit more about the Navigator supports and other services that Camden has been offering New Jersey providers.
Thank you, Meryl. Thank you everyone for having me here today. We can actually skip this slide, Travis, because this was gone over by Gwen and Steve already. Thank you. But as mentioned before, this role utilizes experiential knowledge, skills, and coaching to guide and assist individuals to obtain and maintain services designed to assist individuals in maintaining recovery. So these tasks really include that care planning on the non-MAT component of care, as well as care coordination, to ensure that when appropriate, individuals are connected to community-based substance use counseling and assist them in resolving identified needs. So our organization, we tailor our training curriculums to fit the roles and responsibilities of these OBAT navigators. In the training, which takes place twice a year, it used to be in person, which transitioned to virtual during the pandemic, and we'll see what happens next year, but we may be offering sort of a hybrid program. And it includes sort of an overview of MOUD, which is led by the Centers of Excellence here. Oftentimes, we, get told by OBAT navigators that before they even get to do care coordination with the patients, What we hear is that they really need to build and maintain relationships with individuals first. So they need to have that rapport and trust in order for patients to engage and stay engaged with them. So we focused the other part of the training on skills for building relationships, care planning and its documentation, as well as putting harm reduction and trauma-informed care into practice. Lastly, we developed tools for identifying resources and build relationships with partners to get individuals connected to where they need. And in 2021, license-specific CEUs are going to be available for those who attend the training. We also have some tools and resources that we offer, including example care plan templates. Often we get asked about documentation care plans, and we found that this is really helpful for a lot of folks. Some use this as this template as is, others use this template as a base and then modify it to best fit their clinical needs and their own electrical health records. We also manage a curated social service database that navigators can use to look for any social programs, from housing to transportations to finding an identification and the processes for doing that. Our organization also provides support on specific questions and processes in getting OBAT navigators registered into practice. And while most of these resources are designed for navigators, providers and other office supports are welcome to join the training and engage with what we offer here. We understand that care not only starts when you sit down with the providers, but at the registration. So it's actually have been really helpful to have other members of the team join these trainings and support events as well. Other ongoing supports that we have include a monthly navigator support calls and skills lab, where some months we do a quick didactic plus a deep dive on content such as trauma-informed care, harm reduction, de-escalations, etc. And then other months we do case presentations where navigators come together to listen on a challenging case and then share out thoughts and suggestions. So this really provides that space for navigators to connect and learn from one another. And lastly, we co-host an MAT lunch hours with the Centers of Excellence here, which is an hour-long virtual meetings to hear from experts and discuss the latest updates in clinical and non-clinical issues affecting the MAT patients population. And this is open to all providers, OBAT navigators, peers, advocates, and other stakeholders working in the New Jersey substance use disorder fields. Our website is listed on the slide here, but I will also add a link and our contact information in the chat. And I'll go ahead and pass it on to Dr. Bastin.
Actually, thank you so much,
Oh,
Moy.
Clement, I'm sorry.
No worries, no worries. Thank you so much, Moy, for your presentation. I really want to highlight that collaboration is so vital in terms of our shared mission to really increase access to treatment for substance use disorders. So really appreciate all the work that you do. So in terms of our work and NJ MAT Centers of Excellence, this presentation is really about talking about the resources as well as the services. And I'll turn it over to Dr. Bastin later in this slide deck to talk about a lot of the services that we do as part of the Centers of Excellence. So next slide. So our main objectives of this is to really introduce, and I know Steve had mentioned our role for the Centers of Excellence in supporting the office-based addiction treatment providers. And of course, we'll talk about the resources and services. So next slide. I think the most important thing to talk about when we talk about shared goals and vision is really the importance of flipping the script, right? That substance use disorders is not really a disease of moral failing, disease of moral choice. We really want to make sure that the language is about it's a disease, it's a chronic disease, just like hypertension, diabetes, or even HIV and hepatitis C, all these as chronic diseases. And so by thinking about that as a chronic disease, our role is to really increase statewide capacity to provide evidence-based treatment. So not just providing a treatment, but also ensuring that's evidence-based for patients with substance use disorders, focusing on medications for addictions treatment, right? And that's the terminology that we'd like to use so that there is no there's not that stigmatizing thought, the idea that, it's not assisting treatment when we think of medication-assisted treatment, but rather it's medications for addictions treatment. And of course, increased capacity to provide recovery support services. So we do provide a lot of mentoring education. So we want to be that clinical support arm. We are there for you as new providers or existing providers and providing that clinical support as you provide substance use disorder care. And of course, building working collaborations within the community, and of course, conducting research and developing innovative models of service delivery. One important point I wanted to mention as part of Steve's presentation is that the integration of substance use disorder as a chronic disease and ensuring that office-based addiction treatment providers, really primary care, family care, or really any other specialty can really provide treatment for patients with this disorder. And lastly, our vision is to end the stigma of addiction and ensure that those suffering from substance use disorders have access to high quality evidence-based treatment so they may live full and satisfied lives. Just like any other chronic disease we see, hypertension, we want to ensure that the therapy we provide, the medications that are provided are really there to improve quality of life. And that's that's the goals and vision of approaching patients who are suffering from this disease. So next slide. One of the key resources I really want to highlight is our NJMAT COE manual. So this is a manual, it's a comprehensive manual that really supports an office or clinic-based practice to prescribe these medications for addictions treatment. And the focus is on medications for opioid use disorder at this time, given the data and the studies showing the benefits of it in terms of reducing morbidity and mortality. We also have some information on alcohol use disorder in this manual. But overall, we're here to support medications for addictions treatment. So it's not just opioid use disorder, but if you have any questions or any concerns or any support needed for addressing any substance use disorder, we're here to provide that. So this guide also provides information on how to integrate substance use disorder treatment as part of your general medical practice. And of course, this guide is really the primary focus is on providing that clinical evidence-based treatment, right? How do you initiate medications for addiction treatment, such as buprenorphine? How do you maintain? What's the appropriate dose? What's the latest literature guidance? This is provided for you in this document that is continuously updated as more literature comes about. Next slide. And we have other resources posted on both our Northern and Southern New Jersey Center of Excellence websites, which will be provided at the end of this section of this slide deck. We have lots of resources developed in collaboration with our colleagues at the Camden Coalition, information regarding social determinants of health, harm reduction, legal issues, special populations, such as how do you approach treatment with addictions in patients who are pregnant, for example. We have useful links and of course, clinical guidance and lots of handouts available on both our Northern and Southern Center of Excellence websites. And one thing I want to highlight is just because we have two websites, whether you're from the Northern counties or the Southern counties of New Jersey, resources are, they're not limited to geography. So you're able to utilize resources from each of our websites and which we kind of work together to ensure that we have all the resources available to help you. We also have information on our newsletters and of course, holding events such as our learning collaboratives, those telehealth, the tele-education series that we do. So next slide. And then this is just a sample of our newsletter where we provide information on headlines in substance use disorder treatment, recent upcoming events such as the MAT lunch hours or any of the educational series that we do, consultations that we do with many of our providers. We also provide recent literature. What's some of the recent literature that's seen in treatment, such as the best induction strategy for buprenorphine. Any of the literature that's upcoming or that's available, we'll post it in our newsletter. And of course, any new resources that we are creating as part of our Centers of Excellence will all be in this newsletter. And the newsletter is archived and we're working on a way to make it more accessible, so easier to retrieve information that might be displayed in previous newsletters and make it easier for you to get that information. So now I want to turn it over to Dr. Baston to kind of talk about our services and kind of a lot of the additional things that we do. So Dr. Baston, take it away. Thank you.
Thank you so much, Clement, and also thank you, Moy. It's so wonderful to have this collaboration and really be able to highlight it here. I can't thank you each enough for basically being able to help people get access to this, not just the materials that I'm about to talk about, but also really being able to walk through the process, because you can read materials, we can figure out, you can learn how to do something, but what we really want to do is walk people all the way through, right? How do you get people in your office to be certified as navigators? How do you get that billing up and running? And the coalition has just been so instrumental in that. And we want the same thing. So what I'm going to talk about now are really the resources that we've taken, not just the information, but how we're trying to make that available to you as providers in the community, and what we really want, how we want to be able to engage with each other so that you feel like you have that elbow-to-elbow support, as we like to say. You have somebody right there helping you with difficult cases or with a question about systems. So here are just 4 of the highlighted ways that we really try to get that information, not just available for you to read or go look for, but also we really try to reach out to you. One of those is another collaboration with the Camden Coalition. We do learning collaboratives that offer continuing education credits. They are Zoom platforms, so anybody can get on them. They're over a lunch hour, so hopefully they're accessible. I know it's tough to squeeze that into your day sometimes, but we want to make it accessible, and we highlight experts on those talks. So they all have a topic of interest, and then there's a ton of interaction and question and answer. We have breakfast clubs, which is another way that we do kind of learning and really grassroots mentoring in the communities. This is county-based. We've really focused on these in the South, especially where there's some more rural areas. We have county-based collaborations where we bring people, and this is really cross-disciplines, cross-different kinds of treatment facilities. We have methadone programs, these office-based addiction treatment, harm reduction, and syringe access programs. We have community behavioral health, hospitals, emergency departments, all coming to the same collaboration meeting. And we really talk as a community about what our counties need. So on the ground, where are the gaps? Where are people falling through? What happens when someone goes to the emergency department? How can they follow up? Are we really doing a good job of bridging in communities? What happens at 2 a.m. when someone needs help? And who's there to get them that help? What happens when people don't have insurance? So that's what those are for. And they also can have some just clinical mentoring. So we'll often discuss, with outpatient identifiers, just challenging cases or things that have come up for people. And that way we as a Center of Excellence can really support people on the ground. And the last, but maybe most accessible thing that I really want to highlight is just our 24/7 text hotline. You can call or text, but the text really helps just be able to make this available in the community and helps you triage time a little bit. So this is for provider-to-provider medical questions. So basically, if you're seeing a patient in the community and you don't know what the right next thing is, or somebody has had a bad event or something's happened and you don't know how to clinically manage it, you can just text this helpline. You text that number on the screen, and then one of our providers is covering it 24/7. We can just either text you and answer back, or if it's a complex case, we'll call you through the app, and you'll just get to talk to us, and we'll talk out medical recommendations right there in the moment. We know that when you're on the fly with patients, it can be really challenging to just go find resources that you need, and sometimes you just need a clinical answer right at your fingertips. Next slide, please. We also offer more individualized services. So those are, what I just talked about are resources for everybody, but we also want to make sure that people can get more of that elbow-to-elbow support for their own institution. So we've done things like do site visits. We've gone and done entire presentations to emergency departments that want to start initiating buprenorphine in the ED or other medications. We do alcohol use disorder treatment in the ED. We've initiated methadone in emergency departments. Like Clement said, which I think is so important to highlight, we don't just treat opioid use disorder. So any substance use disorders and complex syndromes with multiple substances involved, we really want to be able to offer that mentoring and education. So if your institution really needs additional support or help, feel free to reach out to us as well. Next slide. And this just is a map of the physical areas that we cover. Mainly, again, just like Clement said, are resources you can use from anywhere, and you're welcome to hop on any of our learning collaboratives. But if you need help in your specific area or for your institution, you can take a look at this map to see who's covering your county. Next slide. So just to kind of wrap up, I wanted to talk to you a little bit about our future goals and where we're hoping that we will be able to go from here. Of course, we highlighted social determinants of health, but we know that's 80% of health, right? So housing, working on people with who've been incarcerated and reintegrating into community, trying to decrease that and trying to get more treatment for people rather than incarceration or punitive. People who don't have any access to insurance or have gaps in Medicaid. These are communities that we really want to focus on in our kind of up and coming programs. We actually just got funded by the state to offer medications and medical services and transportation to people who do not have insurance coverage or are experiencing a gap in insurance coverage. This is really for people who meet criteria who are below 350% of the poverty line. But in general, we just really want to get that access to people who don't have access to their regular medical insurance. And that's available at both centers of excellence right now. And we're also really working on strengthening those warm handoffs and collaborations. I heard an excellent question by a healthcare system about, hey, how do we get this list of OBATs so that we can really connect our patients to community-based treatment? And we're working on some systems-wide, easily accessible connection tools. And so we're going to keep partnering with New Jersey to get that really accessible with you. And our state has been such an incredible partner in really recognizing the need for that and wanting to move that forward. Next slide. So we just have some resource links here. Feel free, please, to write that number down so you can text us. You can get on our learning collaborative through that link or our lunch hours. You can go to either of our websites and you can get on our listserv so you get our newsletter. We'll probably make these available in the chat. I'm sure you can reach out to get these again, but thank you so much for your time, and we're here for you. We're excited to get people really up and running with us on the ground.
Awesome. Thank you so much, Dr. Baston and Clement and Moy. Really, really informative presentation. And we have a number of questions already coming through, and someone already downloaded the provider manual and is just blown away. So thank you for making those resources available to folks in our community. I'm going to ask all of the speakers as well as their colleagues to join us on camera here for Q&A. And we have a number of questions, so feel free to just unmute yourself and jump in. Some of these are not directed to a certain person or certain organization. This first one, though, Moy, is directed to you, and someone has a question about the My Resource Pal and if that's available to everyone or who it's available to.
Yes, that's a really great question, and I should have gone over it, but this My Resource Pal is in fact available to everyone, and everyone including patients. So not only can navigators use this, but also providers can use this, and they can also have their patient access this themselves. And so it's made to be as accessible as possible, from anywhere from cell phones to laptops and things like that. So we often find that providers will, make referrals through that platform, and or print out certain information, give it to the patients, or if it works better for them, they could email it directly over to the patients.
Thanks, Moy. And if folks have additional questions about My Resource Pal, should they reach out to you? Is that fair to say?
Yes.
Okay, thank you. I just want to acknowledge a couple of folks have asked about a link for the newsletter. We will be sharing the slides after the webinar, which includes the link, and I also just dropped that into the chat, but let us know if you have any difficulty accessing that. One other question was around continuing education units, and folks are curious if those are available for social workers or just for medical providers. And I'm assuming that's for the learning collaboratives, which I believe are what the CEUs are available for.
Yes, I can answer that. Those sessions that we've been doing Fridays, and there's additional sessions too, but they're available for CME, medical nursing, pharmacy, and social work related to which those are our Project ECHO learning collaboratives.
Thanks, Clement. So another question from Lee. This is a great question. Thank you, Lee. Is there any plan for the Centers of Excellence to provide support for behavioral health providers in addition to medical providers? I'm not sure who's best equipped to answer that, Dr. Zerbo. I don't know if that's something that you want to take, or Iris. I'll defer to you all.
Sure. As the psychiatrist, I'm happy to jump in. So we actually do offer support for behavioral health providers because those kind of prescribers can be OBAT. So just want to make sure that psychiatry is involved in this. And we actually are making headway with the state psychiatric hospitals to present to their teams and whatnot. We're very interested in the behavioral health space in general. It's just a matter of kind of funding and focusing our efforts, et cetera. And so we would love to expand more and provide more support in that area in the future. But right now we're really focused on OBATs and growing the prescriber network. But that's another direction we need to go in. Caitlin, I don't know if you want to add anything to that.
No, thanks, Dr. Zerbo. I think that was great. It's always one of those challenges of where do you go first? And we do have incredible behavioral health support networks and other behavioral health providers in the community that are doing this work, but it's unbelievably important to collaborate. I will say that when we do our breakfast clubs in the South and also the learning collaboratives and our lunch hours, we do get an interdisciplinary team attending all of those. And so it is on the ground support that's not just focused on the providers, just like you said. And so really, we just want people on the ground coming together, and that's where we really start making these connections and making a big difference.
Thank you both. So Maria asked a question. She said she would like to share the In the Moment hotline with their emergency department physicians. Is there an email or a contact person that she can provide to their ED physicians if they have questions prior to using the hotline? So I'm not sure if that should go to one of the Centers of Excellence over the other, but it seems like there are questions about the hotline before actually using it.
I'll just give kind of a general answer, but I'd love for my colleagues to chime in. We have a Northern and a Southern COE email. So we have an email contact and a website. I think you can contact us, at least in the South, I know, through the website, and I'd love my Northern colleagues to chime in about kind of a general contact. But please feel free to use the hotline, just text it, see how it goes, give it a trial, and then communicate with us with that. And if you have any issues, we certainly want to get that feedback. And yeah, please feel free to use the kind of general contact, at least for us in the Southern COE, which is on our website.
Perfect. Does anyone else want to add or elaborate on that?
I just wanted,
Go ahead.
Clement, because I'll let you talk about the hotline after. I just want to say, while we're kind of answering this question, I want to encourage the audience to chat any questions about treating these types of patients in a primary care setting, because I know that can be a big shift for people where they're worried about urines or having substance users in the waiting room, or how do we shift into addiction treatment. And we'd love to hear kind of particular barriers people feel might exist, either at the organizational level or even just personally, or colleagues that just any kind of barriers, so we could talk through that. Because I think that would be the most helpful way to spend the rest of the time on this seminar, because what we found is that when people get into addiction treatment in the primary care setting, it's incredibly rewarding. They really like it. The patients like it, but it takes that extra activation energy to get it started. So we'd love to brainstorm of any barriers to that. And Clement, I'm sorry, I'll let you comment on the hotline.
I see that Meryl posted our emails. So we have a flyer that we can also send to you, Maria, that might help facilitate as well. So if you email either one of us here, doesn't really matter who, North or South, we'll definitely send you the flyer, and then you can distribute that.
Awesome, thanks, Clement. So we need to pivot to our next presentation now, but I just want to acknowledge that we are, excuse me, going to have time for additional questions towards the end of the webinar. So as Dr. Zerbo said, really encourage folks to drop any questions into the chat about the resources that are available, but also about treating addiction in primary care. And to our speakers and to the folks on the line, we can compile a lot of the resources that were mentioned today and send them out following the webinar. So you'll have those in your email in the next couple of days or so. So Travis, with that, I think we can actually pull the slides back up. And we can go to the next slide, please. I am very pleased to introduce Andrew Johnstone. Andrew is the primary care MAT director at Jefferson Health of New Jersey, and he has joined us here as a provider champion to share more about his experience integrating substance use disorder treatment into his clinical practice. So without further ado, Andrew, I will turn it over to you.
Thank you. Thank you for having me. It's great to be able to speak and just share my experience, especially to advocate for everything that COE does and the Camden Coalition. I guess we can go to the next slide. So I work in Marlton, New Jersey in primary care. I'm going to go over briefly our OBAT program in Marlton. Even though it's been about 2 years of treating opioid disorder or substance use disorder, I feel like we're just at the beginning of our program. We've been fully supported by the Center of Excellences and just completed a year-long implementation project with PCSS for OBAT in primary care. My journey into MAT started when the president of Jefferson sent me a personal email along with the medical director suggesting I attend an X waiver. So I was 2 years into my MP career and I think starting to get a little burnout. And I think I went home and told my wife, like, I'll go, but they can't make me treat addiction, so there was definitely some hesitancy and resistance to it, but I went to the X waiver. I was taught by Dr. Baston and just completely changed my outlook. And that's just continued to be a gradient of change. I think after about a month of getting my X waiver, I signed up for a mentor, which I highly recommend, and I'll talk a little bit about more later. And I did not know how lucky I was to get assigned Dr. Zerbo. And I took that for granted. I didn't know what I had and I didn't utilize it. I think they even scheduled a meeting and I didn't put on my calendar and I missed it. And if you know Dr. Zerbo, you know what a big miss that is. So what happened is I got my first patient, someone who came in looking to start bupe, and I called the hotline and I got Dr. Zerbo. And I was like, wow, this is great. You're also, we're assigned my mentor. And we started 1 month, I don't know if she has the time, so I'm not advocating that this is possible or not. But she started 1 month phone calls for about like 20 minutes, 30 minutes for the first 3 months. And then I think I was kind of off and running. But I've utilized that hotline a lot and I've gotten many different resources to be a hotline. But one of my first patients that I then called directly to my mentor, Dr. Zerbo at the time, was one of my youngest patients who had come in, severe opioid use disorder, fentanyl, heroin, high Xanax, getting prescribed different providers, different states, lots of ER visits, recently was stabbed, would come in just begging, crying, pleading for Xanax. And I think eventually, that was the main driver for him to come in. And I think maybe the third visit, he had been on and off of Suboxone. He was very familiar with it. But he finally would get a day or two on Suboxone, and he came in and we did a urine drug screen. It was my first urine drug screen. And he came back with a little bit amount of bupe and fentanyl. And I didn't know what to do. My prior experience with UDS is it's not good if you're prescribing opioids and you see this kind of thing. So I called Dr. Zerbo and she said, well, congratulate him that there is bupe in the urine, that he is trying, and let him know for his own safety what he's using has fentanyl in it. And I think that, that's that change of mind that you get. So it's, I think it's very important to understand the difference between like prescribing opioids in general, maybe just for pain or whatever it is, and doing MAT. It's the harm reduction approach, which it means that we're not in the role of policing or punitive actions. It allows for honesty with the patient. So when the patient can be honest, that I relapsed, or I'm also using meth or this, and that's not a reason to stop the medication or discharge the patient. it can really leverage what we do, and it puts us in a position in the patient's life that he doesn't or she doesn't usually have. It's usually friends or family that they burn bridges with. So we can be a strong support for that patient. But, I think a lot of the hesitancy is these pain points. What are you going to do if this happens? But it puts you in a role that you're prescribing them medication that's typically it's hard to abuse. Suboxone's not really known for being abused, or maybe Vivitrol for AUD, you can't really abuse that. So it puts you in this position where you're just in a very positive role and a strong support for the patient, and it's incredibly rewarding. So this was my personal antidote to burnout, and it's been super rewarding since then. And we can go to the next slide. SAMHSA also, which I'll show later, has like a black and white what they kind of recommend for UDS. So even though your mentor may say like this is harm reduction, if you need something in black and white telling you kind of like it's okay, we're not meant to discharge when these show up in the urine, if that just for your own confidence, but if you want to show someone else, because I do find we're in the stage now where we're trying to translate what we have down the primary care line, and the UDS is a big challenge. So I'll show you that resource later. But for us on our journey, the phase 1 was learning how to prescribe, assess withdrawal symptoms, how to start the induction, and prescribe adjunct medications, which I'm a fan of. The learning curve is quick. You get a lot of information, and if it's something you're hungry for, about the 5th patient, you'll be starting to feel pretty confident in treating opioid use disorder and alcohol use disorder. I think it's intimidating too, because typically when you go in the room, you have this sense that the patient knows more than you, which is partially true when you start. But like I said, the learning curve is quick. And you can go from feeling like you're on the defense, you don't know what to do, even though you really want to help and you just don't like being in that position, to offense where you feel strong that you can help this patient. So what's worked for us is having leadership support, definitely. And then the endless support from Dr. Zerbo, Clement, Northern Center of Excellence, Dana, Dr. Haas, Southern Center of Excellence, and being supported by PCSS for both clinical and developing policy. All that's played in the role where we are. And so what you should feel when you start this, and if you utilize the resources, that you are supported. You have a hotline, you should just feel completely supported. And if you look at these resources, you'll see there's not boundaries. Cooper, Rowan, Rutgers, virtual calls. It's different. It's just maybe beehive mentality. So you just feel it's contagious too. I want to then help other people who call. So it creates for a provider a gradual experience of safety, where you feel like you're hesitant, you're intimidated till you call. You have that elbow support. You feel like you know what you can do. And in my experience when I started, the directions were very clear: do X, Y, and Z if this and that. And there's some handouts and things that you can give to the patient. So I'm just going to try to speed up. I'll share if I can share my screen here. So this actually, here, can I show? Sorry guys, are we seeing this bubble map here?
We aren't seeing the bubble map, Andrew. I think that if you want to share the version that's on your screen, you can click the share screen button at the bottom, but right now we can just see you.
Okay, we'll skip that. I don't want to, we'll not share that, but if you just go back to that slide with the bubble map, I will share a link to this. What this has is embedded links in each bubble. So when you control click, it will take you to the landing page of signing up for PCSS Mentor. And then there's this toolbox, which I'll try to vet through the Center of Excellence, that's good for handouts for patients. It has a lot of quick resources for providers, and maybe something you want to give to a patient. I highly recommend, so I try to line these bubbles as closer to the OUD as sooner as you should start it. So utilizing your hotlines, the mentor sign up, the clinical toolbox, signing up for the Navigator training, and signing up for SUD Stigma Lunch and Learn by Camden Coalition. I think PCSS offers one as well. It's been incredibly helpful for us to have that's an office staff. So you get your front desk and office manager all on board with this, so they know how to handle when a patient's doing well. They give compliments when a patient's trending up and they're showering and their appearance is different. So I highly next slide. I highly recommend not only having your navigator or your person who's going to be the navigator take the Navigator training by Camden Coalition, but provider as well. It's about 8 hours. I think it's 4 2-hour sessions, and that helps me know where my navigator's head's at. It lines our goals. I understand what she's looking for, what my patient's priorities are. The training gives us language and a framework, which is so important. When you can name it, you can frame it. Teaches very practical things. One thing that's really helped me out build bonds is getting to know my patients. Why are they trying to stop what they're addicted to? What are their priorities? And then this has been really big for me is praising effort and outcome, but focusing on the effort and matching the effort that they put in. I have not had a case yet where a patient is putting in effort, really trying, and we're matching that. And then with the medication on top of that has not had a positive outcome. So just nonstop praising of effort. And then you can also highlight the data of the outcomes from that effort. Another thing that's helped, I think got me really hooked, and probably a lot of people who are in this can relate to, is when you see someone just at rock bottom, like they've just had it, they just feel like they cannot live like this anymore. And you start the medication, and you start to build those bonds, and they start to trend up and up, and then maybe down a little, but overall up. That is very rewarding. And I had this one patient, this young woman, one of the most severe of use, where she was doing plus 40 bags a day, at one point on top of heroin, and just desperately wanted to stop, for herself, for some of her friends who passed away. She had short-term goals of wanting to fix her teeth. She was very embarrassed when smiling. She had wanted to be able to wear shorts in the summer, because IV use, she had a lot of scars and was self-conscious about it. And then she wasn't in nursing school at one point in her life, and she wanted to go back. And we tried Suboxone, but relapse. And then we got on Sublocade. And it took about the 3rd month on Sublocade where she, despite using, she could not feel high. And she sent this beautiful message saying, like, I hate you, I can't get high, but no, I'm actually really happy. And her life trended with that. She got into dentist, she got her dermatology dentist. Things improved. Just coincidentally, she moved to Florida, and we still keep in touch every once in a while. She sends me a message, but 2 days ago, she sent me a message that she moved back to Jersey. She's off of Klonopin. That was our next issue. And she's just how proud, that she is of herself and grateful. But now she's, off all everything. So I think, you'll get that a lot, and you'll get hugs from patients. You'll just see it's very rewarding. And, it is, like Clement said, this is a disease. You got to think of it like a chronic disease. It's just substance use disorder has these ripple effects that some chronic disease doesn't have in their lives and families. So people are very appreciative when you can get this under control. And next slide. Sorry, I wasn't going with next slide while I was talking. This is kind of what the tenets of our care, which we built a lot off of the Center of Excellence and Camden Coalition. And I think I'm wrapping up here. Next slide. And this is just the website to sign up for the X waiver. So I think that's all I got.
Thank you so much, Andrew. That was really, really powerful, and just appreciate you sharing your experience and what you learned along the way. So we have a little under 10 minutes for questions. Andrew, I have some for you specifically, but I want to invite all of our speakers right now to join us on camera as we walk through these last couple of questions. And I just encourage any of the attendees on the line to drop any lingering questions that you have into the chat. Everything is on the table. So Andrew, I had one question for you just about the credentialing process that you went through. And I'm just wondering if at a high level you can speak to what that process was like and what you learned from it that might be useful for other providers that are looking to become an OBAT provider.
So credentialing for the X waiver was pretty simple. You go on that website on the last slide, and depending on if you had the training, you pick your option or not. At the time, there wasn't this option where you at the time when I did it, you had to have the training, but now you don't. I think it's a different limit of patients. But I've now in our own clinic had people go through it. Like they'll just call me, like they're telehealth that day, so they have some time. They'll go on that website and they'll pick that option where they don't have that training. And it's very simple. You just go through it. I don't think there's a lot of barriers, but feel free to message me, or if there's someone you want to email me, whatever, I'll call you, I'll help you. Yeah, and then you just wait. And one way to check if you have that X waiver is to go on to, I think it's the SAMHSA, it's called Pharmacy Lookup. Like if you were to just Google X waiver pharmacy lookup, you go to that page, and it's almost like it's not intuitive because it's pharmacy lookup, but you put in your name and DA number, and then it will tell you if you've been X waivered. It's been taking us since time of applying and checking that website and seeing we're green is about 3 weeks, I think, 3 to 4 weeks. Yeah, that was it. And then for credentialing for OBAT, there is some things to that, but reach out to me. Steve has been helpful, Center of Excellence. Yeah.
Awesome. Thank you, Andrew. So I have a higher level question that I think, pertains to the pandemic and pertains a little bit to federal policy, but I imagine it might be of interest to some of the providers on the line. My understanding is that some federal policy change during the pandemic that allowed it easier to access buprenorphine in a home-based setting. And I'm just wondering if any of you all on the line can provide an overview of that and an update on where that's at in case it's relevant to other folks that we have participating. And I'll throw that out to the group, and feel free to unmute yourself if you're the one that wants to tackle this question.
Clement, I'm like, you should take this one.
Okay, so this is referring to the HHS guidelines that allows for, prescribers, physicians, PAs, APNs, the ability to prescribe buprenorphine for up to 30 patients without needing an X waiver. Now, I think one of the main areas of clarification is that even though you are prescribing to 30 patients or less, you still need a waiver. It's just a expedited waiver where you're able to prescribe without having to go through the 8-hour training of your physician or 24 hours if you're not a physician. So I think that's where, because I get questions about that, like, oh, I don't need a waiver, right? But no, you still need a waiver, but it's just different format, if that makes sense. So you would still we do have like a slide deck as part of our resources that kind of guides you as to where to go in terms of the website and SAMHSA and what to click. And that's available on our Centers of Excellence website. What I'll do is, as soon as I'm done talking, I'll send it over to Meryl, and she can share that slide deck out to everyone who may be interested. Hopefully that would provide a quick overview.
Thanks, Clement. So we just got a question through from Lee. Thank you for your question, Lee. And Steve, I imagine that this is directed to you. Does anyone know if behavioral health providers will be able to access the PMP in addition to medical providers? It would be helpful to know when you are providing care to be able to see what is prescribed. Steve, you're muted. Thank you.
Yeah, I am not that familiar with that. Zankana, our pharmacist, is much more familiar with it. Unfortunately, she's not on the call.
That's okay, Steve. I mean, any questions that we can't answer that we don't get to today, we can circulate after the fact. Dr. Zerbo, did you wanna add anything here?
Yeah, I just wanted to say a huge thank you to Andrew for all the lovely, amazing things he said about me. I feel so good about myself, so thank you. And honestly, we want that kind of path for everybody. Like that's the whole idea about using the hotline and getting involved with mentorship, because what we find is, and I think what he said was so incredibly important, that treating addiction patients in primary care helps solve his burnout. And if you ask a random primary care person, they would say it's the opposite, right? If someone's going to force me to treat addiction, that's what will cause burnout. So I just think it's so cool and awesome that that actually helped prevent it. And I think the reason is that we take this very whole person-centered approach, right? So when we see that urine with fentanyl in it, the usual thing would be like, oh, we got to discharge this person, liability, risk, et cetera. And we're really trying to flip that on its head and say, let's look at the person, et cetera. And then we'll deal with documentation and liability, whatever we need to on the back end, but let's not put the emotions in that part of it. And when you flip that way of working, it's so restorative. And it's honestly neurobiologically how we're designed to work. As humans, we're optimal and we're functioning at our best when we're in healthy social relationships and when it's bi-directional and we feel like, you know, we're assessing and evaluating, we give a particular diagnosis and treatment plan, the patient goes and does it, et cetera. And we have that in so many areas of healthcare, but it's been taken away from us with addicted patients because we live in a society where we have a war on drugs and we have structural racism and we have all these societal factors that have created all this stigma, and the stigma goes into the healthcare office and into the doctor and provider's office. And now you feel that wall between you and the patient where you're like, you're cheating and lying and stealing and you're going to mess up my medical license and my career, and it becomes like you versus the patient. And like honestly, that was a real risk. The reason that that culture has developed is because in the 1920s and 30s there were a bunch of doctors indicted and charged for prescribing narcotics. The DEA is on top of us about prescribing, et cetera. But what we've really seen in the last 5 years, and especially in the last couple of years, a huge shift. And so the DEA is now sending out guidance saying, we're not going after for doctors for buprenorphine. We get it. Buprenorphine is different from other opioids. And so a lot of that fear about liability is old stuff from 10 to 20 years ago. That's not even true anymore. And I feel like when you kind of join our little network and call us and get involved, you can see that culture. And it's so fun to bring that to your patients and bring that into the office. And what I found is that patients with the most severe addiction, when they get into recovery, however far they went down that addictive path, they rebound that far into recovery. And these are people with amazing and incredible potential and energy, and they were trapped and had trauma. And so they went down this dark hole. But as a physician, if you can give that thread to help get them out of the well, and just like Andrew mentioned, they burned a lot of bridges. So their family and friends are sick of it. They don't want to. But we're paid professionally to like just be there with them, not worry about that stuff. I get to be empathic with the patient, close it up, go home, feel like I did a good job. So it's this amazing win-win. And we're trying to give that kind of protective space back to patients with substance use disorders in healthcare. And on a larger level, we need to advocate for an end to the war on drugs and an end to all this ridiculous, kind of focus on the legality of it. But at least right now, we can start by just changing and being more empathic. And the last thing that I'll say, there's a great book called Compassionomics. It's by the CEO at Cooper. And it shows that if you introduce empathy into healthcare at every level, you save money, you have more accurate diagnoses, physicians have less burnout. It's just like I was saying, this is how humans are supposed to function. So for me, it's so fun that we have this like, and fun is probably the wrong word here, but we have like a big societal problem with like war on drugs and drug use. And the answer is empathy. And that actually helps us, it helps our patients. It's about being nice and kind. Like to me, it's just so cool that like the answer is actually just about being nice and including everyone. And that's a lesson for all of us in our lives in lots of ways. So I will get off my soapbox, but thank you.
Thank you, Dr. Zerbo. And I just have to say, like throughout this entire webinar and throughout my work with you all, like what always stands out is the collaboration across the state and like the empathy and the passion that you all bring to this work. We unfortunately are just about at time. I really want to thank all of our speakers. This was incredible. Thank you again to the Robert Wood Johnson Foundation for supporting this work and to all of you for participating in this webinar. We will be sending out an evaluation via email following this event, so stay tuned for that, and we'll do our best to compile all the resources and materials that were referenced throughout the conversation to make sure that those get to you. And then lastly, if you have any additional questions specifically about the matrix model, or if you're interested in becoming an OBAT provider, feel free to reach out to Jonna Lang. Her email is right here on the screen. And we can also send that via email to folks following the webinar. So thank you again, everyone. And we hope you have a great rest of your day.